Good morning, Chris Hull, Wake Forest University School of Medicine, Infectious Diseases with a mid-October COVID update. And we'll talk about a few other things too, not just COVID. So the trees are turning, looking out the window, so fall is here, getting a little bit cooler. Which means respiratory viral season's coming down the pike. Right now, though, we're in a bit of lull, at least for COVID. And I guess it's a little bit of a sad thing when you can reflect back on 3 falls of COVID data. But this is our 3rd fall living with COVID. And like the other falls, October has been a bit of a lull for us. We had our BA4 and BA5 mini surge, mini wave in August. Cases have been coming down since about Labor Day. And it looks like they're kind of plateauing in a trough right now. And that's good. It's about as low as it's been before for COVID. The wastewater also looks pretty good right now. But it's a little bit of a calm before our respiratory viral seasons. In the past 2 years, getting into November, later November, and into December, cases of COVID went up. And that's to be expected because that's usually when we see our flus and our colds and our other viruses that are spread through the upper or lower respiratory tracts. So enjoy the lull right now. Which means we got a little bit of time to do some housekeeping with COVID, and we'll talk about what that housekeeping with COVID might be in a minute. Schools and colleges are doing relatively well, but I can tell you that there are a lot of colds going around. And there's a lot of colds that are associated with some pretty bad sore throats, sometimes with what we call conjunctivitis, which is some redness and inflammation in the eye, both eyes. So you might call that pink eye, but when you have both eyes involved at the same time as a cold, rather than being a bacteria, that's a virus. And it's usually adenovirus. So we keep track of what viruses are circulating through our laboratories here in Forsyth County at Atrium Health, Wake Forest Baptist, and then we also keep track in other hospitals throughout North Carolina. So we have a little bit of a good idea of what's circulating. What is not circulating right now, at least up here in the Triad, is influenza yet. So influenza may be lurking behind that ghost or the skeleton that's out in the front lawn getting ready for Halloween. It's out there, but we haven't been seeing any cases of it yet. So what would be the housekeeping that we should be doing now when things are low? One is get your shot, get your booster shot. So it's time for your fall flu booster, and those are now available. And it's a great time to get it now before the flu season starts. And then the other thing is you can get your fall COVID booster. And as we've been talking about the last few times, the fall COVID booster is enhanced for Omicron, particularly BA4 and BA5. Why is it important to get the fall booster is because the immunity that you have gotten from either past vaccination or from getting infected is not as good against BA4 and BA5. And even a little bit more worrisome are 2 other variants, which I've been watching, the CDC's been watching, and the WHO are watching. So you're ready to write down the numbers. This is BA4.6 and BF7. Both of these are basically Omicron, sons of Omicron. They're mutations of Omicron. They're mutations specifically of BA4 and a combination of BA4 and BA5, respectively. These variants don't seem to be any more severe than the Omicron that we got last January or in the spring or early summer. But they are more immune evasive. And what does that mean? It means that they're more likely to get around the immunity that you built up from earlier vaccination or earlier infection. And that data is pretty much locked down now that that is the case. Also, we are starting to see that here in North Carolina, particularly BA4.6. And it is slowly taking over from BA4 and 5. My prediction will be that by January and February that it'll be at least half of what's circulating in North Carolina in the Triad, and maybe even more than half. And so put all that together means a little bit of a rocky cold and flu season in January and February. That's because of these variants. The good news is the Omicron-specific fall booster vaccine for COVID, the one you can get now, looks like it'll be better for those two subvariants as well, because what targets the parents should also target the kids in the world of viruses. And so that, I think, is going to help people get through the January and February flu season. So will this be like last January and February? No, it's not going to be that bad. The reason why is even the partial immunity that we have gotten from these previous vaccines or previous infection, or the enhanced immunity that you would get from the fall booster, will largely prevent more severe disease, hospitalizations, and death, particularly in those who are not elderly, over 65 or 70 or so, and those who are immunocompromised. But if you are immunocompromised, or if you're older than 65, you definitely want to get the fall booster. I would encourage everyone to get it. But if you're over those ages, it's very important for you to get it, because it'll help keep you out of the hospital this January and February. Other good news on the booster front. Just this week, the FDA approved the fall COVID booster with the enhanced Omicron immunity, all the way down to age 5. So our school-age kids can get it, at least the elementary school-age kids. It's going to be a little bit more of a wait for those under the age of 5, probably a few months, but those over 5 can get it. So if you want to have a better chance of getting through the fall and winter respiratory viral season without having Jane and John home with you for a week because they have COVID, rather than going to school, I would go get that booster. Those boosters should be available for the kids soon, and probably by next week. But the ones for adults and adolescents are out now, so you can go get that. What's going to happen with flu? Some are saying it's going to be a worse flu year based on information we get from the southern hemisphere. If you stop to think about it, the flu season's reverse, right, by hemisphere. So Australia gets there in their wintertime, which is our summertime, and vice versa. So we watched Australia and South America have a bit more flu this year than usual. I think, though, frankly, we're going to have to wait and see. COVID has kind of thrown a bit of a wrench into how we predict flu every year, because, as you know, the last 2 years have been a little bit funny, where we had flu circulating in early fall last year, but when the Omicron variants came around in late December and January, flu just went away again. It's like the two don't like living together. But we'll have to see what happens. Definitely, I would get your flu shot this year, and you can get that shot at exactly the same time as you get your fall COVID booster. I'm going to put my flu shot over here tomorrow and my COVID booster over here tomorrow. And I'll get them both at the same time. Why do I do it at the same time? Because it's convenient. And they work just as well that way. The other thing to remember with the fall COVID booster is the only reason to not get one now is if you've had one in the last 2 months. If you've had a COVID booster in the last 2 months, then you should wait 2 months out before getting the fall COVID booster. Otherwise, even if you had COVID last summer, if you had it last June, I'd go get the booster now. Now's a great time to do it. Let's talk about a virus we haven't talked about for a while. And I say this with a little bit of trepidation. Ebola. All right. So this one kind of snuck up on people a little bit while we were out getting ready for Halloween and enjoying the fall and trying not to think about pandemics or epidemics or emerging infections because we're a little bit tired of the ones we have now. But we have an Ebola outbreak right now in the middle of Uganda. Ebola is a bad virus. And if you remember a few years back, we had the problems with Ebola in West Africa, and they had a few exported cases from West Africa, including 3 cases sent here to the United States. We had some transmission here in the U.S. from those imported cases to healthcare workers. By and large, healthcare workers are probably at the highest risk of a case of imported Ebola. So the outbreak in Uganda right now is due to Ebola Sudan. So that's the name of this virus. The one we had a few years back in West Africa was Ebola Zaire. Why is it important for you to know that? Is because we have a good vaccine and some medical treatments for Ebola Zaire, but we don't for Ebola Sudan. We don't for that. People are working on it pretty furiously right now. It may not take that long to make it. And we'll use the same technology we use to make the Ebola Zaire vaccine. But it means it's a little bit harder to control the outbreak where it first starts, which is in Uganda. Where the outbreak is in Uganda right now are some small villages and kind of a geographically localized area. But there has been one case that came out of that area that went to Kampala. Kampala is a pretty modern city and the capital of Uganda. And so that patient was hospitalized there, but fortunately they knew about it before they got there, so those healthcare workers were able to take precautions. Do we have to really worry about Ebola right now here in the United States? No, I don't think so. So I wouldn't spend much time losing sleep over it. But we do need to take some precautions here in public health. The first one that we're doing right now, from what we learned in the Ebola Zaire outbreak a few years back, is anyone that's coming from Uganda and they're flying to the United States or Europe or other countries are being screened upon entry. And that means they're going to have their health status evaluated, their temperature taken. If they're well, you can move on. But if you have a fever, you're going to end up getting quarantined in a hospital at your port of entry until it's figured out what you have. And that's just a way of keeping Ebola out of our country, and I agree with doing that. But it also means that if you're contemplating a trip to Uganda right now, and we do have a fair number of people doing medical missionaries in Uganda, and they have established relationships with churches in Uganda, and so we do have people that travel there. You might want to think about postponing your trip until the outbreak is over. So in case you get the flu coming home and you just happen to have a temperature, you don't want to spend 2 or 3 days watching Netflix in a hospital in your port of entry rather than coming on home. I'll keep you updated on Ebola. I am keeping an eye on it. So far, I'm not losing any sleep about it. I think we can control it in its current state. But it's just a reminder that emerging infections are going to happen from time to time. They have been for decades now, but we just are a little bit more aware of it, and we have more of a global society now, so we have to respond to that. So with that, I'll take any questions.
So I have a question. So, for people who may have forgotten about the whole Ebola outbreak from like years ago, the Ebola concern from years ago, how transmissible is it?
So yeah, for those of you who forgot about Ebola, and I can understand why you would, how transmissible is it? It's pretty transmissible by direct contact. So it's different than COVID, where COVID, comes out with droplets and occasionally aerosols that go through the air. You really have to touch somebody or their fluids directly. So in Africa, the way a lot of people get it is from handling and washing the body before burial. And people can get it that way. Healthcare workers get it from direct care of the patient and touching them. Healthcare workers can prevent that transmission by wearing the proper protective equipment, and which would include a little bit more than what we do for COVID. It's usually a hooded mask with a breathing device with it, and a suit, like a latex suit. If you remember the old days where this last happened, we do have those. We didn't throw them away after the last outbreak. And the Public Health Department here in North Carolina, both at the state and the county level, we're going over their protocols and identifying hospitals that would care for Ebola patients in our state, should we have one. Not that we're really anticipating any, but should we have one, there's places that are designated and have some awareness on how to do the right protection for it. But yeah, it's a pretty severe disease. About half people die who get it. And it's pretty transmissible if you have direct contact with the person. But that doesn't mean that we can't do things to keep from getting it.
What are the symptoms and how does it affect? I mean, can it be mistaken for COVID?
Yeah, can Ebola be mistaken for COVID? Maybe in the first few hours. After that, probably not. Ebola has a lot more rapid onset with high severity in a person, with really bad headache, really high fevers, really bad muscle aches, and in the first few days, really not a lot of cough or respiratory problems. And then certain laboratory tests can differentiate them pretty quickly. There's a lot of nausea and vomiting with Ebola, not so much with COVID. But I would say probably within 24 hours of evaluation in the hospital for a seriously ill person, we would have it figured out. Also, right now, they would have had to have been coming from Uganda, because there's no Ebola anywhere else in the world.
But, and it's not as, with COVID, it takes a while for you to get it. It's slower getting the symptoms. It's more reactive, quick.
Right. Yeah. With COVID, if you remember, from the first symptoms of COVID are more like a cold or a bad flu, with fever, some body aches, runny nose, and then as time goes on with it, you start to feel better. And then those few people who get very, very seriously ill don't get that seriously ill state till around day 8 or so. Whereas Ebola hits you like a truck, and you're pretty seriously ill from the first couple days.
So, Dr. Ohl, how has dealing with COVID over the last few years changed the way that we monitor and respond to other infectious diseases?
Yeah, that's a good question. So how has dealing with COVID changed the way we respond? Well, in some ways, We're still learning. Let's take monkeypox for an example. One thing about monkeypox, I think while there's been some criticism that it wasn't recognized early. I mean, all in all, if we hadn't have been dealing with COVID and other emerging infections over the last few years, it probably would have gone on quite a bit longer before it was recognized. The other thing is that we were able to ramp our public health education up fairly quickly for monkeypox, again, using monkeypox as an example. Whereas before COVID, I think that would have taken longer, because those relationships that we make, like with you, the media, for instance, are there and present already. So you guys can pick up the phone and say, hey, Dr. O, what's this about monkeypox? Or I pick up the phone and call you guys, and then so we can get the information out. And for instance, with monkeypox, getting the information out on how to avoid and not get monkeypox with high-risk populations really helped, because the number of cases is going down. So I think that's a good example. We also there's been a lot going on behind the scenes with the CDC and the WHO and other health entities and governmental agencies with global health security, and trying to keep an eye on what's going on out there in the world, and particularly in places where it may be not as accessible, such as the center of Uganda. So whereas with the West African outbreak, we didn't really recognize there was an Ebola problem until there probably was already 1,000 cases. Now we caught it at around 50. So that's advancement. So I think there is more awareness of emerging infections. In the long run, we're going to need more investment, though, not only just investment with money into monitoring and responding to emerging infections. And I say not just with money, but also with personnel. We need more shoring up of public health. We need more good isolation beds in hospitals. So there's some ways to go yet. It may seem a little bit odd for me to say, but as far as the severity of pandemics go, COVID was, I mean, it was severe enough, but it could have been a lot worse. All right, well, I'll see everybody back in 2 weeks, and we'll see what's going on, and we'll keep an eye on COVID, and we'll keep an eye on the flu, and we'll keep an eye on Ebola.